Welcome to the Metabolic Link, a podcast that explores the common thread of metabolism in health and disease. This is where science meets society.
Metabolic Health Summit is the world's premier scientific and medical conference on metabolic health and therapies, featuring world-renowned expert speakers, cutting-edge science, an innovative expo, and incredible networking opportunities. MHS is altogether an unforgettable experience for anyone interested in metabolic health.
I think Metabolic Health Summit is amazing. It does such a phenomenal job of bringing world-renowned experts in different illnesses and metabolism, real-world experiences, clinicians, patients, paired with vendors who are trying to make this easier for people. I think for everybody who comes, including myself, learns something.
Join us January 25th to 28th, 2024 in Clearwater Beach, Florida, or attend virtually. CMEs are available. Go to metabolichealthsummit.com and use the code LINK to save 10% on your registration.
Hi, everybody. Welcome to the Metabolic Link. And we have an amazing two guests here today that are speakers at the Metabolic Health Summit, which is occurring just in a few weeks. If you have not registered yet, please do so as soon as possible. We'd love to see you in person. And if you can't make it in person, there's also a virtual component. So today we have two amazing guests on the show. Dave Feldman, he is a senior software engineer and entrepreneur who has really become obsessed with understanding lipidology in the context of his cholesterol, which climbed significantly on a low-carb diet, which he's had enjoyed great success on a low-carb diet and all the benefits that come with it, but the elevated LDL, which many people out there listening may have experienced. He has since performed a series of experiments around this phenomenon and published several papers on the mechanisms of the phenotype of the lean mass hyperresponder phenotype. And he's working with UCLA through a newly formed public charity, the Citizen Science Foundation. So I encourage people to go to that foundation if they're interested in learning more about the lipid energy model, lean mass hyperresponder phenotype, and how to contribute to that research. And we have Dr. Nick Norwitz. He's a PhD. He's completed his undergraduate at Dartmouth College in New Hampshire, graduated there as a valedictorian. He majored in cell biology and biochemistry at Dartmouth. Thereafter, he completed his PhD at the University of Oxford, Department of Physiology, Anatomy, and Genetics. And his thesis was focused on ketone metabolism and neurodegenerative diseases. Specifically, he did a PhD project looking at the effects of the ketone ester. So he's currently a medical student at Harvard Medical School. He's third year, MS3, with plans to pursue residency in internal medicine or pediatrics and a career as a physician scientist. His current research interests are focused on the metabolic effects of dietary macronutrient manipulation, and as it relates to carbohydrate and insulin model, lipid energy model, and the lean mass hyperresponder phenotype. So Nick is an N of one experiment in and of itself, and he is very prolific on Twitter and also has an amazing YouTube page, which I encourage everybody to check out. So without further ado, we have Dave Feldman and Dr. Nick Norwitz. Great. So let's begin, guys. Thank you, Nick, Dr. Norwitz, for joining us. And of course, Dave Feldman, longtime favorite speaker on this topic of lean mass hyperresponder, spearheading research in this direction. No doubt I get more questions about this than any other topic in the low-carb ketogenic space. So I am very excited to hear of the emerging research you guys are doing, and I have a list of questions for you. So maybe just give a brief introduction of who you are and what you do.
I guess I'll kick it off. I'm Dave Feldman. I am a software engineer and platform architect, and kind of got my whole life and career and everything derailed, if you will, after getting a very high cholesterol test after going on a ketogenic diet. That got me obsessed with understanding lipidology as best as I could, doing a number of self-experiments, and then eventually trying to work my way into the field, and eventually connecting with Nick Norwitz and a number of other people that helped us to formalize this research a bit more.
Can you give a brief time frame on that? Because I'm trying to chronologically put this into place of, yeah.
Yeah,
Uh,
quite literally, I got that cholesterol test in November 27th of 2015. So
okay, yep. So
it's
it's a,
yeah, it's been quite a journey. And for what it's worth, at each step, I kept thinking, oh, I'm pretty much done. I think I've got enough that I can hand off to somebody who will take it from here. And that's pretty much, you know, my timeline is a constant attempt to hand things off, but then ultimately getting further and further along.
mhm.
I guess my introduction, I'll run with the timeline thing, thinking about what I was doing in
Yeah.
2015. I had just graduated high school, so as a freshman in college, or maybe an early sophomore,
Oh,
spending a
geez.
lot of time probably at,
Yeah.
I went to Dartmouth College. The dining hall there was fantastic, and we would probably be slamming lots of ice cream and cookies. So I was not keto at that point in time. But at the end of college, I developed pretty bad IBD. And then at the beginning of grad school, when I finished up at Dartmouth, I was studying majored in cell biology and biochem, and then I went over to Oxford to do my PhD. And around that time, I was having a really hard time with ulcerative colitis. So my introduction to low carb was I was trying a bunch of different diets just to see if any would help with my IBD. Eventually, I had tried a ketogenic diet, and it was very effective for me. So that kind of catapulted me into this space, which I was exploring while I was doing my PhD at Oxford, coincidentally, actually, in ketogenics. It was in the lab
Yeah.
of Kieran Clark, who
Mhm.
developed the ketone ester back in 2003. So I was studying neurodegenerative diseases. And when I finished up at Oxford, I came over back to New England from Old England to do my medical degree at Harvard. So right now I'm a third year at Harvard Medical School. And I met Dave, it must have been 2020 or 2021. I it sounds really proximal. It feels like it's been a lifetime, as Dave can probably
Yeah.
attest. I'm like
I
my
thought it was
brother.
like 2019 or 18 or okay, but so much has
Yeah.
happened. Both of you.
2019 was when I tried a keto diet. So that it was
Mhm.
June 1st, 2019. I remember it very vividly. So that was like 4.5 years ago or so, maybe a little bit more. And I had the same reaction Dave had, even a little bit more extreme in terms of my cholesterol response. I had totally normal LDL my whole life. Even on a pretty standard diet, my LDL was like 90, eat whatever I want, more or less, eat a balanced diet, etc. But when I went low carb, and when I did it, I'll qualify because of what I perceived as healthy. My low carb was like basically free of dairy and red meat. It was very Mediterranean-esque. Put quotes there because obviously that's a vague term, but lots of unsaturated fats, fish, and my LDL ended up jumping to the 300s and eventually the 500s with that approach. So to me, that was very shocking.
How
And
fast? Because I have a little bit to add to this, story from my how fast my LDL went up. But how fast did your LDL go up when you
well, at
initiated?
that point in time, I wasn't really following it because I didn't expect that to be a possible reaction. So I don't remember when my next lipid test was after going keto, but it was probably my first test was probably a couple months later. My first retest was in the 300s, and then I've had a peak at 545. And when I had that 540, that's the LDL. And
Yeah.
my saturated fat, my unsaturated saturated fat intake ratio then was like 5.67 to 1. It was an 85% of fat was unsaturated, only 15 saturated, and totally free of like phytosterols. So I'm not hyper absorbing the dietary sterols. So anyway, I was very curious about it, started doing my own research. One thing led to another, and my world collided with Dave's, which I can't tell you how grateful I am for that occurrence. Obviously, I wouldn't wish IBD on myself or anybody else, but the degree to which it's put my life in a new direction, but one with a lot of interest and purpose and a lot of curiosity, particularly around this question of lean mass hyperresponders. I just get up every day and I'm so energized to, study about it, engage with people, learn more. It feels like a niche that needs to be explored. So it's been really cool meeting so many interesting people like yourself, like Dave, from other walks of life, and just being tied together by this question about, well, what's going on here in some lean people who have these massive spikes in cholesterol when they go low carb, and trying to unravel that mystery has been a really exciting part of my last 2 years, and actually kind of kept me afloat during what I hope is the hardest part of medical school, because the last year wasn't all that gentle. But this has been a shining light
Mhm.
in the darkness, to be dramatic.
Well, I admire and respect you guys both for what you're doing, what you're spearheading, and your ability to put yourselves out there. And I'm sure you're facing a lot of pushback, maybe even criticism, like on certain topics that you are advancing. And I'd like to sort of get into some of those topics in particular. Uh, and you guys, I want you to kind of walk me through some of the research that you're doing. But something that consistently comes back to me as a question of saturated fat. Does saturated fat drive LDL? In particular, the lean mass hyperresponder, but in the general population too. What your thoughts on that?
Do you want to start, Dave, or should I?
Yeah, I mean, it's kind of funny. I almost don't want to take the thunder away from Nick, because he actually put some decent work into an article that you can now find at cholesterolcode.com, authored by him, where he really specifically attacks the topic of saturated fat and whether or not it's what's driving increased LDL. Of
In
course,
him, yeah,
well,
as an
not
No,
individual.
not just in him. Yeah,
Oh, okay,
there's
okay, great, great. Mhm.
yeah, so I realize that this is a common expectation, and to really emphasize, we're not suggesting we don't think there isn't any impact of saturated fat that can have that can impact LDL levels. We're talking about a basket of different influences, and when we're talking about the lean mass hyperresponder phenotype, specifically high LDL, high HDL, low triglycerides, that phenotype, that tends to have the highest level of LDL. And when you're seeing that level of LDL, how much is it impacted by saturated fat? Well, Nick just got done talking about his diet, that not only did his LDL go up into the 500s, but on top of that, he was actually, for a ketogenic diet, he actually had a low proportion of saturated fat compared to many others. Certainly, I eat a lot more saturated fat than he does. Go ahead, Nick, you were going to say.
I think just to emphasize that this isn't just I might be an outlier of sorts in many ways, but to kind of go through some of the arguments why saturated fat really isn't a good explanation, I think the first and most obvious is just an order of magnitude question. Can some saturated fat, affect cholesterol in people on a mixed diet? Yeah, maybe a little bit. You get a little bit of LDL receptor downregulation, and you get a little bit of bump. But the order of magnitude we're talking about is bumps of, dozens to hundreds of milligrams per deciliter. Nowhere in the literature is there any suggestion that saturated fat can have that kind of impact in size alone. And then you have to, tack on to that. Well, can it explain the other phenomena we see going on here? So with lean mass hyperresponders, it's a lipid triad. It's not just the LDL. So you see the HDL going up as well. Is the saturated fat really bumping people's HDLs to 90, 100, 110? I've sat as high as 124, as well as other people, plus the low triglycerides. So can you actually explain that lipid triad with the saturated fat? And then, like, layer onto that another thing, the inverse association between BMI and LDL change, whereby leaner people have larger increases in LDL, and this is a dose response effect. So, if you look at, say, the randomized human control trials, and you look at those on lean people and those on people who are overweight or with obesity, you'll see the changes in the lean people, but not in the people who are overweight or with obesity. So is it because the lean people are eating more saturated fat selectively and in a dose-dependent manner? And then you add on to that the fact that people can go on low saturated fat, low carb diets and be lean mass hyperresponders. So you can see that there are a lot of things here that just don't make saturated fat a very elegant explanation. It's kind of a little bit hand wavy, in my opinion. It doesn't really capture the picture.
And
In addition to that,
it's worth
I was
also adding oh, go ahead.
the last thing I was going to say would be there's easy ways to test this, and one would be to do an intervention that would be predicted by our model to reverse the lean mass hyperresponder phenotype, but without reducing the saturated fat intake, maybe even increasing it at the same time. Then what happens? because that, alone should put the nail in the coffin. I will also add one more thing in that all of this is going to be a very moot point soon. I can't tell you why. I can tell you there is a paper in the works, not the N equals one we'll talk about, but a very rigorous paper that's going to be published in a top journal that I think will put the nail in the coffin of the saturated fat question. You'll know what I mean when it drops. And
Can
Dave
you
already knows.
describe? Okay, yeah, I'm totally looking forward to that. Can you describe for our listeners and just to refresh my memory, the cutoff point for the triad for the LDL, HDL, and triglycerides for lean mass hyperresponder? I'm not sure we mentioned that because
Yeah,
there might be
sorry.
some new listeners here. Yeah.
It was, and for what it's worth, Dom, the story behind it's a bit almost comical in retrospect, because it was before I had connected with Nick. It was before I was really even working with researchers. It was in 2017, and it really was just pattern recognition, but it also kind of fit into the early rumblings that I had on the energy model. The cut points are an LDL cholesterol of 200 or higher, an HDL cholesterol of 80 or higher, and triglycerides of 70 or lower. And it's worth emphasizing all three of the things I just mentioned are already rare. Like individually, they're already rare.
Yeah.
But the thing that I was going to say from earlier that kind of ties in nicely to this is we didn't really see this before, even in the days of Atkins. And I would argue that the reason there's a historical context, which is that people like the three of us on this call didn't really have a reason to decide to cut out carbs, especially if we were interested in athletic endeavors, right? If we were pursuing fitness, the interest was definitely the opposite, that you needed to carb load, that you needed to top off your glycogen stores and so forth. And it really wasn't until quite literally, I want to say like the last 8-10 years, truly, that there actually was more of an interest, not just in going low carb-ish to where you might be like, say, at 100 grams of carbs, but for many of us going actually ketogenic, where it might actually get down towards like, say, 20 or 30 grams of carbs. At that point, then there was this new phenomenon, if you were metabolically healthy, that started to emerge, and that's when the pattern was much more recognizable. So I would see that not only people would have high LDL, but also they tend to be leaner. They would not be the people who would typically go to see Dr. Atkins back in the day, or who themselves were deciding, what the heck, I might as well just try this other diet where you drop carbs, we have lots of saturated fat because I'm already in a metabolic crisis to begin with. These were folks who were like, hey, I want to see what happens with my athletic performance if I go on this. And that's why some of the earliest, not quite lean mass hyperresponders, but certainly hyperresponders that we know of were with the work of Volek and Finney, because they were interested in the athletic components with the ketogenic diet. So that's why I think it's kind of it's a good opportunity, I guess you could say historically, that as this emerged, at the same time, we had social media to be able to observe this a bit more often.
Yeah, and it's not really a feature of the ketogenic diet literature with kids and stuff that are on a very high fat, very low carb ketogenic diet. It's not overtly noticeable, at least. I mean, there's some clues in the literature, but it's just not a feature of kids, pediatric population, or even adults that are not necessarily obese or using it from the epilepsy literature. And that's kind of like our best literature. We're going to put, there's RCTs on ketogenic diets for epilepsy, and that's probably our best literature on ketogenic diet metabolic effects, and it has not been seen. So I thought I was kind of an outlier when I started seeing this, and I started getting more and more and more emails. And then, you start doing this research. So it's kind of weird that it just didn't surface from the epilepsy literature. But I think it lends to that idea of a lean mass hyperresponder athletic phenotype.
Just to add real quick on the epilepsy, because we ourselves for the documentary were reaching out to doctors of epileptic patients specifically. One of the challenges is, and I say this with kindness, including children today, they tend to not necessarily be as lean athletic, especially if they've got medical challenges they're working through. But we have interviewed some that are going to be coming on the documentary. I can't steal the thunder from that just yet. But sure enough, that were much more lean, much more athletic, and they do tend to exhibit the phenotype depending on what their medical their medicine regimen is, because there's that component too. The other issue is that epileptic doctors, such as ones that are connected with the Charlie Foundation, they're understandably concerned about discussing this out loud, because oftentimes, epilepsy is the first thing that everyone wants to care about dealing with. And, cholesterol comes up, but that's okay. There's this, there's a suite of different drugs for cholesterol lowering medication. But this is all the more reason why we want to get this data out, especially with regard to risk, is they should have those answers for those people who especially are using it for medical efficacy. We want to be able to tell them, this is what we do have for right now on risk with these individuals.
And they may have been taken off the diet because of that, and that doesn't show up in the literature, which I'm aware of numerous cases for that just through email. But yeah, the late John Freeman, Eric Kossoff's mentor, passed away in 2012, I think. There was a publication with the elevated triglycerides and elevated cholesterol mildly, but my thoughts are that the elevated triglycerides are a feature of someone really not adapting well to a ketogenic diet and maybe taking in surplus calories. But that was a paper that was often referenced for the atherogenic risk of ketogenic diets. But I think kids, were definitely removed because of this reason.
For sure, there could be like many reasons that LDL could go up. So say somebody has high triglycerides, it could be a genetic factor. It could be, chronic excess intake. I think that's the power of identifying the triad as being something that all three of these things coexisting is very improbable unless they're part of a particular pattern. It's like rolling 100-sided dice 3 times and getting the same number every single time. It's just not very probable. And you do have to kind of weigh specificity against sensitivity, like any medical tests. The thing we get often is it just made up? Or a similar question, am I a lean mass hyperresponder? Here are my numbers. To that, I'd say, well, to the former, yes, it's made up, like everything else in medicine, like syndrome X became metabolic syndrome, et cetera, et cetera. You identify a pattern, a syndrome, a set of characteristics, a phenotype, and you name it. And then you use that to study it. But as you well know, for classifying things and studying them, we usually do have to come up with cut points. And the physiology does not care about the cut points that medicine comes up with. We just create them for classification. But, if somebody's looking at their lipid panel and asking, am I a lean mass hyperresponder? Well, the criteria are clear in terms of the cut points. But if your LDL is 199 and that's the only reason you're not meeting it, it's like, well, that's just, it doesn't really have that much bearing on your physiology. It's like asking the question, do I have diabetes if your A1C is 6.4 instead of 6.5? The answer is, well, you don't quite hit the threshold, but does it really matter? Again, arbitrary cut points, the physiology doesn't care about them, but we do need them for some degree of classification. And I think maybe just by coincidence, the 280-70 cut points do a really good job of, picking out the true positives while not getting too many false positives. So balancing the sensitivity and the specificity really well. I don't know how Dave did it. He might have had like a time machine or something, but
no,
it's for now.
The person missing from this call, but is part of our trio, is Adrian Sotomoda. And one of our favorite moments ever for all three of us was when he got a hold of data. I'd gotten a lot of survey data from people who were turning in their numbers, just lipids in general. And he did a hypothesis naive analysis. So it's like machine learning, where basically it's telling us what it's finding. And it was finding a triad very close to the lean mass hyperresponder phenotype. So yeah, I'm excited because I feel like so much of the advancement that we've had in the research, ironically, was in helping to identify this phenotype, because that helped to also do the retrospective analysis, to be able to look back at NHANES, just a triad in general, maybe not as extreme as lean mass hyperresponders. How often do we find observationally that a population with high HDL, low triglycerides, but also high LDL have an association with cardiovascular disease, all-cause mortality, or even getting down into things like cancer and infection and so forth? It's really quite fascinating. But the challenging part is that it's not just that we're identifying this phenotype and we're studying it. There is a claim that's being made by the lipid energy model paper, which Nick has helped us put together, and we have a list of 5 different ways in which you can test it. And one of them is that we think this really is physiological. It's not just that it's random chance. It's not that it's just unusual genetics. We think most people who you get that, like, say, are Nick, we could design a diet, put people like Nick on it who've never been classified as a lean mass hyperresponder. And I think that we'd find the vast majority of them turned into lean mass hyperresponders. And if that's true, it's physiological.
Can I add one more really important point that might not come up in a question, but I really want to hammer it home, which has to do with classification. And sometimes or there's a tendency, maybe prior to, but even still, identifying lean mass hyperresponders as a unique phenotype to lump them in with another class of patients, familial hypercholesterolemia. And you even see a tendency towards this with the changing criteria for what is familial hypercholesterolemia. Now with definitions relying more on just the phenotype, so a phenotypic definition, i.e. if your LDL is above 190, you can be classed with familial hypercholesterolemia. Now, that is a problem in my perspective, because what it does is it clusters people that are lean mass hyperresponders to people with a genetic etiology, a congenital disorder, a broken lipid metabolism from birth. And, that driver is very different than a metabolic driver. And the consequences, therefore, could also be very different. So you have very different etiologies. You could have different consequences. You don't necessarily have different consequences, but you do need to separate them to start to have the conversation. So, I think it's important to do the T-chart, compare these two things and say, are they the same? So you have FH, you have a mutation or a set of mutations that are altering lipid physiology from birth. It's congenital. It might be a phenotypic diagnosis, but it's a genotypic disorder. It's driven by your genotype. You have it for life. It doesn't, get really influenced by carbohydrate restriction or environmental factors like the lean mass hyperresponder phenotype, and you don't have necessarily the HDL and the triglycerides that are associated with it. Whereas the lean mass hyperresponder, these are patients with presumably normal lipid metabolisms that respond to carbohydrate restriction in a reversible manner. And it is associated with this triad and other features that we see, like the inverse association between LDL and BMI. So I just want to highlight that, you could see how, if one isn't looking for LMHR and trying to distinguish them, those patients could get brushed into the FH category. And then you have an issue of signal to noise, right? Where you have phenotypes being mixed together and you might not actually see the signal that is lean mass hyperresponders and be able to distinguish it, what makes it special and what we can learn from it. So step one is identifying this as a unique phenotype, which I think we've now effectively done. Have a model to explain it, and then pursue that model, mechanistic questions, and then the risk questions as well. But I think it's really important to, distinguish why the triad is really valuable in classifying this group. Hopefully that's all clear.
Yeah, one of the questions I have is so an LMHR person who's really high on the spectrum and they have a family history of ASCVD, like what do you do in that context? So, I mean, I've gotten that question several times over the last month or so. So someone's cholesterol is off the charts, everything looks absolutely perfect, but they have a concern because of the family history of it, and they're not, they don't have genetic predisposition for hypercholesterolemia. So do you have those people in your trial, actually?
We actually do. We have about 31 of the 100 have reported a family history of heart disease, which surprised me. Like, I didn't actually realize we'd have that many folks that would actually be in there. Dr. Budoff, I'm going to steal his answer because I myself am always uncomfortable if somebody's asking me, especially if it comes down to individual health advice. I pass the ball off and say, work with your doctor, do the best you can. But Dr. Budoff, at the end of his presentation of our match analysis, which we might get a chance to chat about, somebody had brought forward, another fellow doctor had asked in the Q&A, had said, we get some of these folks who have gone on a ketogenic diet and they have a profile like this one, and we're very uncomfortable with it. So are you suggesting we just ignore the high LDL? And his answer was that what you can do is you can get a scan. Because of course, what they found with both CCTA and CAC is that even in those folks who do actually have genetically confirmed familial hypercholesterolemia, if they have, like, for example, a 0 CAC, especially, later in life, it's very low likelihood that they're at as high a risk. But of course, conversely, if they do have present disease, then that's, something you want to be considering as well. So that's not my answer. That's me kind of carrying over his answer. But he and Karam Nassir, who's also the senior author for the upcoming match analysis, are on lots of papers where they're looking at exactly this. And that is something that I think is just a fair statement overall, is if you're concerned about your, heart disease risk, whatever the circumstances are, then I don't think anything really beats actual detection of the disease. And this is why I love that we're using CCTAs in our study, because now the radiation dosage is so low that if you really want to go for the gold standard, you can get it for like 2 millisieverts of radiation dosage, which is, but like 5 mammograms or something along those lines, depending on if you're already low risk. And just find out for yourself if the disease is already present, and then that will probably inform your decision a lot more.
Quick question. So, according to the lean mass, or according to the lipid energy model, does reducing LDL pharmacologically, say from 300 to 150, is that going to impair lipid transport? Is that going to inhibit fat oxidation? It's another question I got, and I'm not sure you've kind of addressed that issue. Like, LDL in your mind is serving an important purpose, and if all the health biomarkers are good and you cut it in half pharmacologically, is that then going to impair lipid transport and fat oxidation? Does the model suggest that?
I can answer that, but I just want to rewind a little bit so that topics don't bleed into each other and really separate the idea of mechanism and risk, because those are two very separate conversations. The lipid energy model, we talk about the mechanism driving it. We don't necessarily talk about risk. And the prior question you asked also, what would we do? Well, actually, none of us here are clinicians, but certainly, not the clinician for the person listening to this video. So it's really important to emphasize that asking questions about what causes the lean mass hyperresponder phenotype, and even asking the question, are LMHR participants at increased risk, as we're doing in the LMHR CCTA study, asking the question, that is at the boundaries of the unknown, is not the same as saying this is safe or making any sort of recommendation. All we're doing is asking questions. We're not managing, as clinicians, as cardiologists, any LMHR patients. So to separate those things. And now, as for your question with respect to driving down pharmacologically LDL and how that could impact energy trafficking in lean mass hyperresponders, I have a thought, but I'll pass it off to Dave if you want to have a first whack at it, Dave.
Yeah, I mean, it's interesting because you, Nick, have some firsthand experience with this more than I do, which is actually kind of cool.
Okay, well, I'll say first, it's an open hypothesis. I would think, if we were like, ask the question, what would we need to do to explore that possibility? One pretty cool experiment I'd like to do is actually a randomized crossover, looking at different LDL lowering techniques in lean mass hyperresponders. But if you had a control group and it was blinded, and you give participants who are LMHR, non-LMHR participants, say, a statin, if there is an impact on fuel trafficking, we should be able to detect that. We could get things like, respiratory quotients. We could monitor symptomology, look at, creatine kinase, lactate levels, this, that, and the other. There are a lot of ways we could monitor it. I could see it splitting either way, to be perfectly honest. I could see a scenario where, yeah, if you're reducing flux, then you might have issues with, say, athletic performance, side effects like myalgias. That said, I did say reducing flux. Taking a medication that reduces LDL doesn't necessarily reduce flux, because when you take, say, all of these medications, they converge, the mechanism is increased LDL receptor expression. So, your body could still ramp up VLDL export and turnover, and you're just having the LDL particles pulled out of your blood more quickly. So it's not necessarily that just because you have a drop in levels, there's enough drop in flux to cause a deficiency in performance. So, my hypothesis is that in a subset, at least, we probably would see higher rates of negative effects and changes in fuel trafficking dynamics, possibly athletic performance, than in the average population. But, as I'm explaining it here, you could see how it could cut either way. So it's a good question that we don't have an answer for. But we can
My
speculate.
hypothesis is it would take a lot. Like taking something from 400 to 150 with a cholesterol-lowering medication that ultimately had to do with receptor activity. So in other words, it has less to do with what's inbound and more to do with what's outbound, right? As less the faucet, more the drain. If the drain is getting larger, right, so that more is getting taken out, but there's still 150 that's detected, it doesn't take much widening of the drain to bring it from 400 to 150. And I think that actually doesn't change the bioavailability that much if we're going to get into like physics of stuff. I think you really do have to get it way down before you can actually create some kind of a systemic rate limitation. That's my hypothesis.
Okay. So then there's not in the context of the lean mass hyperresponder, there's not necessarily a negative functional outcome to if all the biomarkers are great and they want to proactively decrease the single biomarker from 400 to 100 even, you would hypothesize there's not going to be a functional consequence like a decreased VO2 max or decrease in athletic performance. I think that
I was
could
saying that
be a
it's
simple study, like 3-week study.
I think it's a study that we need to do. I don't even know if it made into our final wish list on the lipid energy model paper. I think it's one we need to do. And just to clarify, we've never discouraged anybody from taking medications very clearly. In fact, you
Oh,
can look
yeah.
in our Journal of Clinical Lipidology editorial where we say, look, there are a lot of unknowns here. We don't know that these patients are at increased risk, but in the absence of this knowledge, it's also appropriate to be clinically conservative on a patient by patient basis. So that's perfectly a reasonable choice. And it's very possible there isn't a negative functional effect. But then it's also very possible, or let's just say possible, because it's an open question that the patients aren't at increased risk. Is there any possible downside to taking medications that aren't necessary? Is another, again, just open question. So it's just the question. That's the thing. It's like all these things are giant question marks, and we just want more data so people can make informed decisions based on what the data show. I'll say I've had a statin recently. We can talk about this as part of an experiment. For me, I did have myalgia, and it wasn't super pleasant. I finished the trial, but that's just a little thing. Did it impact my performance athletically? Not really. I could go work out. I wasn't having like statin brain or whatever. I was able to get through life, but I also don't know if I was benefiting at all. So it's not fun to sign up for a drug for life that could have, negative effects on quality of life, possibly downstream consequences if you don't know what the pros versus the cons are. And that's where we are, a big question mark.
Have you tried Zetia? So I just actually took my first dose of Zetia yesterday. So I'm doing a little 30-day experiment on my cholesterol and ApoB. Actually, I experienced some side effects this morning from it. So I could tell like
What were
my
your side effects?
absorption. I had some pain underneath my ribs, like just kind of feeling a fullness. And then I could just tell because I had like maybe 6 to 8 eggs yesterday and some steak and everything that I did not absorb fat. I could tell there was, lipids after the bowel movement, not to be too prescriptive, and that's not normal for me. And I know that's the main side effect. They say it's only like 4 to 6%, but then I read some things say like 20 to 40% of people.
Yeah.
And if you're on a high fat meal, this is what Zetia is going to do. So, I'm super interested in seeing how this moves the needle. I suspect I'm a hyper absorber, but I don't know. I think this little trial I'm doing will.
So, yeah, I actually have tried it. I had similar effects in about a week. I didn't stay on it. I will say, ideally, I mentioned I want to do a crossover. I want to do a crossover with carb reintroduction versus statin versus Zetia. My prediction is Zetia is going to perform relatively better as compared to other patient populations, lean mass hyperresponders, because what it does is it blocks cholesterol absorption from the gut. Now, it's really important to emphasize that's not just dietary cholesterol. You mentioned you had a lot of eggs, but that includes cholesterol that's put in via your bile duct and gallbladder, which is about 80% of it. So
Yeah.
in lean mass hyperresponders, it's not that they're necessarily eating more cholesterol, but because there's more lipid flux, you're going to have more enterohepatic circulation, which means you have more cholesterol kind of fluxing through your entire system. So it's blocking that I think is going to have the biggest impact, and then kind of force the biggest adaptation and increased LDL receptor expression in the liver. So I speculate that Zetia might actually outperform statins in lean mass
Mhm.
hyperresponders. I
And
don't know if that's the case, but
yeah.
We
if we do this
have a little bit
that
of
might.
anecdotal data from the groups on that. That it seems to be better tolerated. Again, this is just anecdotal of what's being talked about out there. But it's interesting. Bill Cromwell, who is of course on Nick's paper that's going to be upcoming here shortly, he was the first to bring to my attention that, as it happens, a number of people who go on cholesterol-lowering medication like statins will actually become hyperabsorbers after the fact, suggesting that the body's like, potentially reaching for and trying to acquire more. But to Nick's point, yeah, our body's actually very greedy with its cholesterol, and a lot that's getting recirculated, with the bile salts and so forth. It's coming back through the enterocytes at a surprisingly efficient rate. So it doesn't take much, kind of with what we were talking about before. It doesn't take much uh, um, inhibition of that in order to change the dynamic a lot, to where all of a sudden now there's going to be more demand on the liver to pull more out of circulation to then use more for the bile. So that's not too surprising.
Not to be too graphic, but like I've gotten some questions, and I kind of can relate to this most recently, is that I think I am a hyper absorber of fat and cholesterol. And I noticed after the Zetia, sort of my poop was floating. And other people have commented about this, that they can eat a ton of fat and they don't gain weight. And I curiously asked questions, or people have asked me about this. And I'm thinking that, yeah, I mean, I think there's something to study there from people who have maybe fat malabsorption that could tolerate a lot of fat in the diet and that don't gain weight. And I think could be, microbiome. It could be the Niemann-Pick 1 receptor, which I think the NPC1L1 receptor, right? That's in the gut. So that plays a big role, cholesterol, but it's also in the liver, it's in the pancreas, it's in other places too, right? So do we know how Zetia is functioning in the liver relative to I always think about it in the gut, but I know it's also in the liver too.
I
I've
don't
only known
know.
about its impact with the gut. I didn't actually know if it had an impact with the liver.
I'll also say I'm definitely a hard gainer with fat, but I've never had steatorrhea. I don't know that
I
that would
never
be,
did either, ever, until I took Zetia.
but I'm
Just
saying
one
if,
dose.
yeah, well, what would be interesting if we had a crossover trial and the arms were long enough, if people on the Zetia arm who are LMHR lost weight, it would be interesting.
Yeah.
Um, yeah, some competition with Ozempic there. Anyway, but I don't know. For
Not
future
that lean mass
exploration.
hyperresponders need to lose weight. They typically are
I know.
Yeah.
already pretty lean. So yeah.
So women, my co-host Victoria is a female lean mass hyperresponder category, and you guys published a paper looking at elevated LDL in women. Did the women remind me? Maybe you could talk a little bit about that paper and what hormonal observations that you saw with these women that had elevated LDL.
Sure. So this was an interventional trial. It was conducted by Dr. Isabella Cooper. And she was doing a trial where she suppressed ketosis in women who were just doing a ketogenic diet by their lifestyle choice. So I think the mean was 3.9 years they'd been keto, something like that.
Mhm.
And then there was 3 phases. The first where they maintained ketosis for 21 days. Nutritional ketosis defined as all participants had ketone levels circulating of greater than 0.5. And then they suppress ketosis with 21 days using the standard UK healthy eating guidelines, or SUC for standard UK guidelines, also SK for suppression of ketosis, where they suppress their ketone levels below 0.2 millimoles, eating around 200-ish grams of carbs per day. The recommendations were like 55% kcal from carbs. along with most eating guidelines. And then they went back on the ketogenic diet, and and that was the intervention. They were looking at a lot more than just lipids, but we did a sub project where we were looking at what were the changes in lipids. And two things fell out. One was a confirmation of our prior work that there's an inverse association between BMI and LDL change. So the women who were leanest had the highest LDL and the largest drops when they added back carbs. So that was a confirmation of prior work. Now, lipid energy model, emphasis on energy, we would presume that things related to energy in the body are going to be predictive. And so another thing we looked at was thyroid hormone, because thyroid hormone controls energy metabolism. And we're able to find that free thyroid hormone also predicted changes independently of BMI. So if you end up looking at the paper, there's a nice spider plot that shows the power of different predictive models. BMI is the best solo predictor. Thyroid is an independent predictor, and then combined, they provide an even better prediction. So yeah, that was the hormonal finding. We don't report on sex steroids in that paper. And I'll also note the interpretation is not entirely clear. It was specifically the free thyroid that changed, not the reverse thyroid, not the T4. Actually, it might have happened with the T4. The TSH was normal. Basal metabolic rate didn't change. So we can go down the rabbit hole of that a little bit, but more than anything, I'd say that there was an association between a hormonal mediator of energy metabolism that predicted LDL change in addition to BMI, which is, consistent with the lipid energy model.
Yeah, so insulin suppression of insulin, like there's that iodo-deiodinase enzyme that T4 to T3, and maybe the suppression of insulin signaling is decreasing or favoring T4 over T3, more active thyroid, but this does not seem to impair fat oxidation, or it's almost, what are your thoughts on that? Because I get a lot of questions about ketogenic diets and thyroid in females, and they seem to be very, very concerned about it. There doesn't seem to be any pathological risk associated with this T3 suppression, right?
Not in this context. I mean, it's the explanation for the etiology of the dropped free T3, which is the active hormone. There could be a few things. One could be increased sensitivity in the pathway. It's really important to emphasize, if somebody is hypothyroid and they have, suppressed metabolism, they're feeling cold, those are clinical signs. Or if you're hyperthyroid, you could have like eyelid retraction, hyperreflexia, you're hot all the time, this, that, and the other, your basal metabolic rates increase. But again, they're clinical signs. And also, depending on the cause, your TSH, which is part of the feedback system, can be changed. So if you're hypothyroid, your TSH is going to go up. Now, there's something called sick thyroid. We can talk about that later. But bottom line is the feedback mechanism, the TSH was totally normal in these women, and their basal metabolic rates did not change. So they're not going clinical hypothyroid or anything. Another possibility is that, thyroid hormone is needed in carbohydrate metabolism. If you remove the need for it because you're eating fewer carbs, then it could just be a supply and demand issue. So, it might be more of an epiphenomenon, a marker, rather than having anything to do with cause of the LMHR phenotype. For that, we'd actually need to do assessments, see if there are, changes that will be consistent with a subclinical hypothyroid. We didn't see any signs of that, and these were very healthy women. So, again, the interpretation is difficult, but no, there weren't any clear pathological signs, no suppression of metabolism or anything like that.
Cortisol?
And cortisol, we didn't
Yeah.
report on cortisol in this particular paper. And I think the data will be made open access. So this was part of a PhD student's project or thesis. So normally, while we would make all data open on this population, there are more papers coming out with respect to this cohort that are relevant to somebody's thesis. So it'll come out in time, but there are reasons we're not reporting on that right now. And that just has to do with that. Her thesis comes first.
Okay. Yeah, I'd be interested in like estrogen, testosterone, cortisol, and if that's correlates with any of this.
When we published the lipid energy model, I mean, we addressed, and I believe we've made mentioned at least once or twice on hypothyroidism as being part of the cascade. And it's a part that we haven't explored very deeply. This is why it was great to have this study to help fill in more. But it's true. I think it's still part of the larger cascade. We know what's at one starting point, which has to do with the hepatic glycogen stores. And we know that whole body fatty acid turnover is a big part of the lipid energy model. But everything that's a part of that cascade in the middle is going to take some time to work out. But I definitely think the thyroid's a big component there myself.
What is your T3
testosterone.
What's that?
What do you, I actually have never asked you what your free T3 runs, because I run really low on T3.
Yeah.
And I can tell you I do not have a suppressed basal metabolic rate.
I think
I'm normal, but
I think I'm at the bottom of the range and potentially below. But as you know, my first author paper, I had published all of the data. I captured a huge amount of data, and T3 was one of the things that, sure enough, tracked with insulin levels. For example, when I was at maintenance level, it was here. But then when I went hypocaloric and it went down, my T3 went down right along with my insulin, and then it went back up right along with the hypercaloric phase. None of this should be very surprising, but in the context, or I should say, should be surprising outside of what kind of diet I had. But in the case of being fat adapted, I think we're going to find it's very relevant. And I think it's why there's so much. It's interesting because a lot of people on a ketogenic diet are concerned because all of a sudden they're getting diagnosed with hypothyroidism. And again, pattern recognition, I think we see this a bit more in people who are metabolically healthy than are not. And I think that there's going to be more dots that we can connect with subcutaneous adipose tissue in particular in that management with thyroid. So we'll see.
I think it can bump up and maybe even overshoot when you reintroduce. This happened to me, in some blood work I did pre 2006, 7, and 8. In 2007, my LDL was about 100. So right now it's about, 240 or something. So it's more than doubled in that time. And I was eating like moderate carbs. But I've also just in thinking about this a little bit more with lean mass hyperresponders in males that have sent me blood work, they are also borderline, if not hypogonadal, and had trending on lower testosterone levels. But these guys are like overachievers in the gym. They're strong, they're fit, and I just thinking, maybe they just have high androgen receptor sensitivity or something's going on there, but they're also probably overtraining in my estimation. And I've wondered if, if you're doing these studies, if you're looking at hormone profiles in particular in females, but also in males, and if you see trends for the males to be a little bit on the hypogonadal end.
I'm just going to say no.
Okay.
Without too much further detail. I have actually tracked my testosterone over time, and it can fluctuate. Let me just leave it at that without any exogenous input. I'm intentionally speaking vaguely. But even when my testosterone is either on the lower side of normal or high being 1,000, 1,100, it doesn't really impact my phenotype that strongly. I haven't noticed anything. Now there's a lot of noise to go with that signal since I haven't been tracking it fastidiously. But I've seen several profiles. Certainly, I think there is a feature of overtraining, relative energy deprivation, and sports type physiology. But also seen people that are LMHR with higher levels of testosterone in particular. So, 900, 1,000, 1,100, just naturally, and LMHR phenotype. So I don't know if you've observed anything, Dave.
I mean, I see what gets reported in groups. I suspect testosterone, as with a few other hormones, especially a few other sex hormones, I think that there's a lot of context that's still getting worked out. That's not just individual, but if there's anything that I hope people can take from my earlier hyper obsessive experiments, it's that once you start increasing the frequency of how much you test, you start to figure out that there are a lot of things that can be influenced in a short time span that don't get picked up by a lot of these larger studies that spend all their money on these incidental, like, once every 3 months or something along those lines. And there are some things I think are more likely to be put in that category than others that may be getting influenced in short time spans. And definitely testosterone is one of them, which is why, by the way, if there is anything I do get a bit vocal about, I wish that they hadn't dropped off fasting. It used to be if you got blood work, you need to be fasted like 12 hours, 14 hours, something like that. And I know clinical practice has changed, but I think we're going to find a lot of data is going to get looser, and things like hormones, particularly that can apply to metabolism and can apply to your circadian rhythm, things like that. I think our data is going to get a lot worse from that one change, and it's going to get harder to assess things like this. And so that's why sometimes I put in a little mention like this in interviews where I'm like, I'm actually a little more of an unknownist than I may sound, because I think there's so much that we still have to learn. And part of it is just getting to this level of granularity.
And that's part of the Citizen Science Foundation kind of overall objective, right? Is to just kind of get into the weeds on these things and get testable hypotheses that you can feasibly answer, get an
Yeah,
answer to. Yeah.
it's funny. I feel like, I mean, I built the Citizen Science Foundation. For anybody who's not familiar with it, I literally started it. It's a public charity mainly for the purpose of funding this lean mass hyperresponder study that we're doing out of Lundquist. But I will say this, there's been a lot of people who reached out to me who are like, this model seems like it can actually work. The studies can get done based on popular interest to do the study. Like you'd think if it was a popular interest, then governments would get behind it, companies would get, but no, it doesn't work that way at all. It's in fact, it's very difficult to get something a lot of people want to know happen without something like this. And so to your point, Dom, yeah, I've kind of thought a lot about, as we move these studies forward, how much can we help make this model more accessible to do exactly that for other people, including other questions like this. It's true. I'd love if we had a big gajillion-dollar lab. I'm sure Nick and I would have about, I don't know, 100 different experiments going on at all times. But yes, getting back to the granularity, getting back to the frequency. I mean, here's a good example. Here's something I wish science would just do today. I wish we just had a bunch of people, like 1,000 people, who we just paid a per diem, and it was just their job to get tracked constantly, right? But like a healthy population. We just don't track healthy populations in general unless there's some business interest or business case that's associated with it. And then it'll be proprietary data. But I wish it was something like NHANES, just a lot more frequent, where there was just a lot more frequent testing, whereas like part of their job to get blood work more often. If there was like new machines coming online that got, new FDA approval, and you only are looking at them with sick populations, well, then we should have some of these folks go through it, and then PhD teams and so forth could connect with it. Anyway, I kind of want a soapbox there, but this is kind of an issue that I feel like we have with science. And I feel like what we've been doing lately has helped to shine a light on that a bit more, which I appreciate.
Do you love learning about metabolic health? So do we. It's why we created the Metabolic Initiative, an online educational platform providing evidence-based education on metabolic health and therapies for healthcare professionals and the general public. By joining the Metabolic Initiative, you'll gain access to hundreds of expert lectures, interviews, panel discussions, and even private episodes of the Metabolic Link. CMEs are available. Go to metabolicinitiative.com to get started. And as always, thank you for listening to the Metabolic Link.
Prevention, there's no research in prevention, and that's kind of, in a way, that's kind of what you're looking at. You're not really treating, I guess, hyperlipidemia is, a disease, I guess we think, because we have a statin to knock it down, right? So we have a pharmacological intervention for that. But where do you see, maybe give like the 5, 10, and 20-year vision of what you plan to do through Citizen Science Foundation and your overarching objectives and ongoing, past, current, and future research.
We're gonna try to like hire amazing people like Nick Norwitz if we can. I mean, I don't know. The competition's going to be tough to try to get him on board, but yes,
He's a bit of a slacker. I don't know about it.
No, but
I've been looped in.
It does
Hopefully.
start with people who just genuinely they're just interested in helping to get to the answers, the truth seeking. That's what's exciting about it, Dom. Like I miss engineering. I miss writing code a lot, but I will say it's very addictive to feel like you're on the trail of truth in some fashion, to just try to figure out what's going on, especially if you might be getting under the hood of some real physiology. But that's what I hope it could be. I hope as an entity, it can not just be looking for new ways of chasing down the same things. I'm hoping we're well past the lipid energy model, in 5 years, and we've got a new expanse of a lot of new things that we could be working on. And yeah, in 10 years, I hope it's giant. Oh, it's a giant lab that's constantly connecting formal and non-formal citizen scientists on really great and interesting questions that are not getting answered elsewhere.
And you have a vision to collaborate with like mainstream academia and to partner with academia to, for example, get NIH R01 grants funded and to get government support behind this. I know that's going to take some time, but I see that as sort of like a bigger grand vision that could really start to move the needle on some things.
What do you think my purpose is?
Well, I imagine you're the guy who I can eventually say, now run this for us.
Yeah.
Yeah, this, like I said earlier, this was really a colliding of worlds for me because that is my academic trajectory. I went to, you know, good college, good grad school, but like very normal down the pipeline, Harvard Medical School. This is where I was heading. The fact that I got connected with Dave in citizen science was a beautiful surprise. You ask about 5, 10, 20-year goals. I would be lying if I said I had a refined image of what that was for me, just because I know how rapidly things are changing for me now. Where I was 5 years ago, I could not imagine where I will, where I am now. So I don't know what that looks like. What I can tell you is that, for me personally, something I've always loved, and I found this to be a thread throughout my life, is just, being curious and spreading that curiosity. And we live in a really special time now in the 2020s where scientists can communicate with lay audiences. There are growing platforms for that. And there are growing ways in which we can engage everybody in the scientific process and in curiosity, and also leverage that brain powers that don't, we're all natural scientists, you don't need degrees, to the betterment of science. That's what I want to devote my life to doing. I don't know exactly what it'll look like, but it's so incredibly exciting to now see avenues opening up for the ability to spread, our nerd enthusiasm for these topics with other people, and then have them in kind reciprocate and provide us with great feedback and great ideas. So that's kind of what I see citizen science as. And I do think, I don't know exactly what it's going to look like, but going into later 2020s, 2030s, 2040s, what we're going to see is a real melding of Jade Tower academia and ideas coming from people like Dave, who are just, he didn't train necessarily to do this, but he made an incredible observation and got other people excited about it. And that's something that really should transcend, degrees and institutions. Yeah, there's a pragmatic element. And yeah, we're going to get, credentialed or highly credentialed physicians and scientists on this. We already are, and we're going to get the grants and stuff. It's a little bit funny because right now it's just a practical limitation of where we are in our respective careers. For me, it's like I know where I'm going. Right now, I don't have those resources, but I intend to. So if he has no one else to lean on, Dave will be able to lean on me for leveraging those resources. But I do think that the network is growing really quickly. You would have it's hard to imagine just how many, let's say, atheists in the clergy there are with respect to academics that are really interested in this topic. I can tell you, I think it's fine to say, some of them have even come out, there are multiple attending physicians. I've had multiple attending physicians who have come to me and say, Nick, I'm really interested in this. And by the way, I'm also a lean mass hyperresponder. Like, it's everywhere. And I think it's just gonna, have to hit, it's getting close, but it's hitting this inflection point where it's just going to be an explosion. And this is going to be something that, a giant swath of medicine is interested in studying just because it's so freaking cool. So anyway,
Yeah.
sorry, that was my monologue.
Well, that's great. I mean, there's so many upper level academics that don't really have an interface with the general public, like you guys do. And, maybe they get a press release if a big science paper comes out or something by the university, but they don't have the passion. It's like they do science for science. I mean, you guys are doing science not only for science, but to make a huge impact on public health and this emerging problem that kind of emerged out of a low carb community, ketogenic diet community, which I'm kind of ingrained on. And I'm really inspired by what you guys are doing, and not only like the research, but to a large extent, the public outreach that you guys are doing, Nick, through your YouTube channel, and then Dave through citizen science and just spearheading that. And I often have like, PhD students especially come and they don't really know where they want to go. I just say, follow, your passion. If you do what you love and what you're passionate about, you're going to be successful in this. And Nick, I mean, like the world is like an oyster for you. You can just go in so many different directions with your background, but I'm super inspired that you're so passionate about this area of research, and just know you're just going to be, spearhead a major research on a major problem that we have in, the nutritional intervention that we know is so powerful for so many different things. I mean, when I first started this research, it was like pediatric epilepsy, and then in 2008, I was excited because Eric Kossoff published in adults. It works in adult, and now it's just exploded, into low carb conferences. And I'm excited to hear what you guys will be talking about at the Metabolic Health Summit too. So I'm just, you guys, it must be hard to pick what you want to talk about there, but
we definitely have short lists, both of us,
okay.
and we'll be hitting the top ones in the short lists.
Well, you guys inspire me. Thank you for all your work, passion, and attention to this. I can't wait to see you guys soon. Nick, I don't think we've ever met in person. I feel like we've but no.
I've been under a rock. I have never been to a low carb metabolic health conference ever, just because I haven't been able to get away. I wasn't allowed to leave last year, basically. So this year I am emerging out of my shell in person. So yes. Yeah, I'm excited. It's going to be great.
Well, thank you again, both of you, and look forward to seeing you soon.